So I have the privilege to introduce Dr. Anurag Bajaj. He's been with us, what, 4 years? 5 years?
4 years.
4 years. Yay. So Dr. Bajaj has joined us and been with us before COVID, during COVID, after COVID, and that in and of itself is a success around the medical communities these days. He was trained at Wright Center for Internal Medicine and Cardiology. He's a fairly humble person. Again, he only gave me 3 lines, so I may wax on a bit. He has had a passion for cardiology since he was in medical school. And beyond that, I'd say you've been an excellent colleague. You've been a big help to our diagnostics lab and still playing around in the cath lab like me, so he's a little bit old school, even though he's not that old. And it's been a pleasure to work with him and see how he's grown as a professional, and he's here to share some of his wisdom.
Thank you, Dr. Sabha. Okay, good morning, everyone. As Dr. Sabha introduced me, I'm Dr. Anurag Bajaj, one of the cardiologists with Monument Health. And it's a pleasure to be here. As you can see, the topic of my presentation is stress cardiomyopathy. Now, I have a habit of speaking very fast. So in case you don't understand and I'm going really fast, please raise your hand or stop me. I'll try my best to be slow. But this is how my native language is at. It's a Hindi language, so we speak very fast. So when I speak in English, actually, it goes in the same direction, actually. So the stress cardiomyopathy. So before I go into details of my presentation, I would like to briefly define this entity because maybe some of you never heard of this terminology. So it's a combination of 2 words, the stress and the cardiomyopathy. Stress means, you're all very aware, stress, and the cardiomyopathy is actually the weakness of the heart muscle. So it is a condition caused by intense emotional or physical stress leading to rapid and severe reversible cardiac dysfunction. It is very similar to acute coronary syndrome in many ways, actually, and only difference is that these patients does not have any obstructive or significant coronary artery disease. It's not going. Yeah, that's what I'm pressing.
Yeah, we're having issues again. Can we just forward the slide for him and we'll... Can you forward the slide in the meantime? Try it now. There we go.
Sorry about that. So stress. So we all have some kind of stress in our life. I don't think I ever met anyone who says that his life or her life is without any stress. So does it mean that we all are going to have stress cardiomyopathy at some point in our life? If not, then who are the people who are actually at risk for the stress cardiomyopathy? And this is actually one of my objectives for today's presentation. So my objectives are to identify the risk factors for stress cardiomyopathy, understand physiology, clinical manifestation, the practical approach to diagnosis and treatment of these patients, and the potential challenges and unresolved question in stress cardiomyopathy. Now, compared to previous presentation of John's, which has too many statistics, too many data, actually, this is purely a clinical presentation because actually we do not have any studies on this topic. Studies means randomized controlled trial. So there are several alternate terms that have been used in literature for this entity. The most common is the Takotsubo cardiomyopathy, which actually is one of the variant of stress cardiomyopathy. Other syndrome, broken heart syndrome, apical ballooning cardiomyopathy, and Gabor-Schinsherz syndrome. So the Takotsubo cardiomyopathy first described in 1991 in Japan because of its appearance very similar to an octopus pod. Takotsubo actually means octopus pod. It is used to catch octopus in Japan. You can see this on the left side. This is an octopus pod which has a narrow neck, which is very similar to the hyperdynamic base of the heart, and the apical and the mid ventricle is actually more of a globular. So now this is a real definition or a medical definition, which is actually not much different from the definition which I just mentioned. It's just maybe a couple of words different. So it is but each word is important here. It's a acute reversible. See, the patient has a cardiomyopathy since last 6 months. It is not a stress cardiomyopathy. So it has to be acute and it has to be reversible. There's a transient regional left ventricle, sometimes even right ventricular systolic or diastolic dysfunction, which is related to emotional or physical stress in the absence of significant coronary artery disease. And missing any of the points, that means it's not a stress cardiomyopathy. However, I'm going to come to that later actually. Patients actually have no identified trigger for the stress. It was one thought to be a very rare disease actually, but since more and more studies came out, the prevalence of these studies is actually 1 to 2%. The largest Takasabu registry that we have has 3,265 patients, the prevalence is 1.2%. And all other studies, which are actually smaller studies, have prevalence anywhere from 1 to 2%. But I believe the actual prevalence of the disease is higher than that, because a patient who have mild form of stress cardiomyopathy actually never report to the hospital. So what are the risk factors for the disease? The biggest risk factor for this condition is being a woman and in the postmenopausal state. In the international registry, about 90% of patients are actually women, and most of them were postmenopausal women actually. The mean age was 64.4 years. There's also some genetic composition, and the patient who have a psychiatric and neurological disorder, actually, they are the one actually, the disease is very common in these patients. I believe the reason is that because it's a stress cardiomyopathy, so it has to be linked with the stress. But people who have a neurological or psychiatric disorder somehow do not have psychosocial coping mechanism that leads to more stress hormone in this patient and predispose this patient to a stress cardiomyopathy. 10 to 25% of these patients are actually diabetic, which may be because the diabetics have more of a microvascular dysfunction, and this is one of the pathophysiology of this disease. This is just a little bit of overcrowded slide actually. It just gave a lot of example of emotional and the physical stress. The common emotional trigger that we see is suicide, extreme element of anxiety or depression, divorce, death of a loved ones. These are the most common emotional triggers that we have seen. And the physical triggers is mostly respiratory failure, hypoxia, COPD exacerbation, asthma exacerbation. These are most commonly. Now, Monument Health also actually has a registry that started in 2013, and we have so far 174 patients actually who have stress cardiomyopathy. And I was looking at the common triggers in these patients. About 15% of the patients actually never had any kind of a trigger for a stress cardiomyopathy. But the most common reason, the most common physical trigger were again same: sepsis, hypoxia, failure, CNS event. And the most common emotional trigger is like divorce, death of a loved one, death of a pet. So the pathophysiology of the disease is actually very complicated, but that is at the same time, we still do not have answers to each and every question that we need to explain for this condition. Now, there are several questions raised about this condition, and let's see if we can explain by the pathophysiology. So what is the cause of the severe mechanical dysfunction, and why some part of the heart is affected, other part is not affected? Like in a patient with apical stress cardiomyopathy, why is only the apex is being affected, but why not the base? Why not everyone get a stress cardiomyopathy if they are exposed to the same level of stress? Why do patients with stress cardiomyopathy do better compared to patients with the acute coronary syndrome, even though they may have a similar degree of myocardial dysfunction? Why it is more common in females? And what is the mechanism of the recovery? Why these patients recover so quickly compared to the patient with a myocarditis or acute coronary syndrome? And why some patients with stress cardiomyopathy, even if they recover their heart function, they continue to have arrhythmia, chest pain, exertional limitation? So there are two elements that needs to be considered when we explain pathophysiology. One is the brain. We have an emotional center in the brain, in amygdala and hypothalamus. So whenever there's a stressful event, our brain senses that, and it releases a stress hormone that via hypothalamus pituitary adrenal axis release the stress hormones by the adrenals. So since not everyone gets stress cardiomyopathy, that means it's the perception of the brain, how much stress is it taking and how much stress hormone is it releasing. And next is the heart. So how is the heart is reacting in response to the high stress hormones? How is the sympathetic nervous system, how our autonomic system actually responding to the high cortisol level? So since it's a stress cardiomyopathy, so it has to do with the stress hormones, and stress hormones are the catecholamines. As we know, epinephrine, norepinephrine, these are basically the stress hormones. So one thing is sure that, based on the data that we have it, that this disease is directly or indirectly affected by the stress hormones or the catecholamines. If you measure the catecholamines in these patients compared to the patient with the acute coronary syndrome, which is also a stressful event, actually the cortisol level are significantly higher in these patients compared to acute coronary syndrome. If you give a high dose of catecholamines to a normal person, they will develop a stress cardiomyopathy. In a patient with a pheochromocytoma, which is a disease of the catecholamine where the excessive surge of catecholamine, they also develop the same stress cardiomyopathy. Only difference is that the trigger is not the stress, but the trigger is because of a tumor that is releasing the stress hormones. And in a CNS event, whenever it's affecting the posterior part of the brain, you release, like a subarachnoid hemorrhage, you release a lot of catecholamines actually, and these patients do develop a stress cardiomyopathy. So that is pretty clear that there is a role of catecholamines in this condition. So how does the catecholamines affect the heart? It can affect the heart by causing dysfunction of coronary micro or macro circulation. In some of these patients, if you take them for a cath, you might find that these patients have epicardial spasm, but not in all these patients. So that means, yes, there is a dysfunction of the microcirculation or even sometimes spasm, but that is not the only mechanism because we are not seeing the spasm in all the patients. But the other mechanism could be direct myocardial toxicity, which could be because of causing inflammation, generation of the reactive oxygen species, directly causing cardiomyopathy and mitochondrial dysfunctions. These are some of the other things by which the catecholamines can cause cardiomyopathy. Now, epinephrine, as you know, is one of the catecholamines, and some of you might be thinking that the catecholamines is actually inotropic agent. Most of you seen in intensive care unit setting, low blood pressure, weak heart. Let's give epinephrine, increase the blood pressure, increase the heart contractility, and yes, that is true. If you're given the low dose and the moderate dose, because it works via beta or beta 2 AR receptor via GS stimulatory pathway. However, if you give catecholamines in very high dose, actually, it has a negative inotropic effect because there is something called a stimulus trafficking, in which there is a change in the receptor going from GS stimulatory pathway to inhibitory pathway, and actually it works as a negative inotropic agent. So the question here is that still why in Takasabu apex is involved but not the base. And some of the hypotheses based on animal models is that the apex and the mid ventricle actually has more of a beta receptors, but the basal part has less receptors, but they have more sympathetic innervation. So in response to the high catecholamine, there's downregulation receptors more in the apical and the mid ventricle, but not in the basal part. That's why the basal part still is hyperdynamic, but the apical and the mid ventricle part are more sensitive to catecholamines, and it has a negative inotropic effect on these segments. Other question is that, but what happens in patient who has maybe mid ventricle? In these patients, the apex and the base is moving fine, but the mid ventricle is not affecting. And again, this is just a hypothesis, it never confirmed, it's just based on the animal model that maybe due to repeated stress cardiomyopathy, there is a downregulation of myocardial receptors, so that can cause differential regional distribution of the beta receptors in other location than the typical stress cardiomyopathy, and that may be the cause of a atypical or other variant of stress cardiomyopathy. This is just a diagrammatic representation of what I just talked about, how the sympathetic storm works actually. So by beta receptor, it causes a negative inotropic effect. It can create some inflammation in that part of the heart. It can generate reactive oxygen species and make the muscle ischemic, which can cause a prolonged QT interval, and that can cause arrhythmia. That's why these patients are very high risk of ventricular arrhythmias, and that's why these patients need to monitor in telemetry at least 48 to 72 hours. Now, there's also a hypothesis, or there's some evidence you can say that it may be actually the cardioprotective mechanism of the heart because of very high cortisol. Because of a very high cortisol causing negative inotropic effects, sometimes it can cause irreversible injury to the heart as well. So by changing the receptor from GS to GI pathway and making the heart weak, it is actually preserving the myocardial integrity and prevents the cardiac death. Second is that it can also activate the anti-apoptotic pathway, and that also prevents the myocardial deaths. So we have different hypotheses based on this condition. But again, some of the data is still not very clear. Some of the data is based on the animal models. Some are actually based on expert opinion. So why postmenopausal women, or maybe why women actually? Because there's a high, again, it's expert opinion that there's a higher prevalence of anxiety and depression in women actually. So that's why they are more risk for a stress cardiomyopathy. In postmenopausal women, they're actually even higher risk because of lack of estrogen, because estrogen has a sympatholytic effect. So when the postmenopausal woman, the estrogen is less, that predisposes patient for microcirculatory dysfunction. They also have a higher element of anxiety and depression and increase in nitrotic peptides. So these are some of the hypotheses that this is likely the reason why the postmenopausal women are affected. In our registry at Monument Health, actually, they were 99% women and only 1% men. And I think only one case was in person less than 60 years of age, but almost all of them were more than 60 years of age. So clinical presentation. The clinical presentation is very similar to acute coronary syndrome. When the patient comes to the ER for the first time, sometimes you cannot differentiate at all. The symptoms have typical chest pain, shortness of breath. They may come with ventricular arrhythmias. Actually, 10% of the people present with a cardiogenic shock. So at one point, this condition was thought to be a benign condition, but actually it's not that benign as it was thought to be. In examination, depending on how stable the patient is, that patient may have a normal vitals at all, but the patient, if it's in shock, may be tachycardic, sweaty, hypotensive, and you may hear a systolic murmur because of a left ventricular outflow tract obstruction. When the apex is weak and the base is hyperdynamic, it can squeeze the muscle into the left ventricular outflow tract, and that can cause an obstruction, and that can cause a cardiogenic shock. So diagnostic test, very similar to the patient with acute coronary syndrome. You basically start with the clinical presentation and go to EKG. Now these patients can have ST elevation, they can have a ST depression, they can have a TU inversion. However, if you're seeing a ST depression, it is very less likely that this is stress cardiomyopathy. Stress cardiomyopathy mostly have elevation or a TU inversion. Next is the cardiac biomarkers, troponin. The troponins are elevated, but compared to acute coronary syndrome, they are not that elevated. Like if you're seeing a troponin of, that is traditional troponin of more than 10 nanogram, which is equivalent to more than 10,000 actually, that is less likely stress cardiomyopathy and more likely a acute coronary syndrome. Stress test, actually, we never do a stress test in these patients because before we do a stress test, many times we have a diagnosis. Echocardiogram actually hallmark in this condition, and I'm going to come to that because that is going to show us actually how the stress cardiomyopathy look like, and a good cardiologist looking at the picture one time and can make a diagnosis very quickly. Coronary angiogram, again, in a coronary angiogram, you may find that patient has no obstructive CAD. Patient may have a CAD too, but if you're not seeing any evidence of acute plaque rupture or acute plaque fissure, that means the patient can still have a stress cardiomyopathy, and CAD is just an incidental finding, and which can happen in about 15% of the patients. Coronary CTA is a test that we can sometimes do in hemodynamically stable patients when the patient is not willing to go for a cardiac cath, and it might just show the same thing, that there's no obstructive CAD. Cardiac MRI is rarely required in this condition when the patient ejection fraction is not getting better after a few weeks and you're still in dilemma. Is it stress cardiomyopathy? Is it something else? So there's something called a delayed gadolinium enhancement, which we do not see in a stress cardiomyopathy, but we do see that in patient with a myocarditis, which is in one of the differential diagnoses, or a patient who had a previous infarct. Now EKG is pretty interesting. The only problem with the EKG is that EKG is very hyperdynamic. There are some findings in the EKG which are very specific for stress cardiomyopathy. But you may see that findings now, and you may not see that findings after 30 minutes because it keeps on changing. That's why it's very hard to just make a diagnosis of a stress cardiomyopathy based on EKG findings. But these are some of the findings. I took it from American College of Cardiology review article. And if you see ST elevation AVR, and when combined with ST elevation V1, V2, V3, 2 out of 3 leads, that is pretty 100% specific for stress cardiomyopathy compared to acute coronary syndrome. If you see ST elevation in AVR and a T-wave inversion in any other lead, that is also 100% specific. Absence of reciprocal changes, absence of abnormal Q waves, and some of ST elevation in lead V4 to V6, more than V1 to V3, that is also pretty specific for a stress cardiomyopathy. But again, you have to be very cautious about this. As I said, these are dynamic changes, so you may see it one moment, and second moment you may not see that. And again, you do not want to miss the patient with the ST elevation myocardial infarction as well. So I'll be very hesitant in completely making my diagnosis just based on these EKG findings. Biomarkers, as I mentioned, the troponins are elevated, but they're not that elevated. If you're seeing they're elevated more than 10,000, that means it's something else, not really stress cardiomyopathy. It's very interesting that BNP level actually is disproportionately elevated in these patients compared to ACS. With a similar amount of left ventricle dysfunction, stress cardiomyopathy patient actually has a higher level of BNP compared to a troponin level. So now come to the anatomic variant. So first is the apical variant, which we also call as a Takotsubo cardiomyopathy, in which the apex is not moving, the mid ventricle is not moving, but the base is moving. Other variants are the mid ventricle, in which the apex is moving, base is moving, but the mid ventricle is not moving. And actually, these are the patients who are more hemodynamically unstable compared to the apical variant. There is something called the reverse or basal, in which the apex is hyperkinetic, but the base is hypo. And sometimes you can see in rare cases the focal, and sometimes that is difficult to differentiate, is it a myocarditis or really stress cardiomyopathy? And I guess you make a diagnosis. If it quickly improves, it's likely a stress. If it does not improve, it may be a myocarditis. And sometimes we see a global in which the whole heart is actually weak. So this is a typical picture of a apical or a stress apical cardiomyopathy, in which you can see that, or you can appreciate that the apex is not moving, mid ventricle is not moving, but the base is very hyperdynamic, and this hyperdynamic base actually can cause obstruction in the left ventricular eye-flow tract and can cause a cardiogenic shock. This is a left ventriculogram, and if you can appreciate that, the base again is hyperdynamic, but the apex and the mid ventricle is not moving, and it's very similar to the octopus pod actually that I showed you. This is a mid ventricle stress cardiomyopathy, again a left ventriculogram. The apex is squeezing well, the base is squeezing well, but the mid ventricle is not squeezing well. So how do you make a diagnosis? And the diagnosis is basically start right from the age and the gender of the patient. If the patient is presenting with a ST elevation in EKG, then you send the patient for a heart cath. Doesn't matter how much suspicion you have for stress cardiomyopathy, ST elevation, the patient go for a cath, you find that there's no obstructive CAD, and then you start thinking about, oh, it could be stress cardiomyopathy, and then you start doing echocardiogram and other workup. Clinical history, I already talked about. They have presentation very similar to acute coronary syndrome. So what I do in my practice actually, so with the patient coming with a STEMI or ST elevation, these patients go to the cath lab. If the patient has no ST elevation but depressions or T-wave inversions, and if the patient is hemodynamically stable, then I do not send this patient for a heart catheterization. I usually wait. If they're in heart failure, I put the patient on heart failure medical therapy, just basically stabilize them, and repeat the echocardiogram after 48 to 72 hours. And if it is really stress cardiomyopathy, you won't believe it, 90% of the time, I will see some improvement in the function of the heart. If I see the improvement, then I know that it's likely stress cardiomyopathy. And also also how the left ventricle look like in stress cardiomyopathy, that also gives you a hint that this look like a stress, function is improving after 48 hours. And now you can, if you have not asked for any trigger, now you can go back to the patient and then ask for triggers in their life, either emotional or physical triggers. So there are several criteria that has been proposed to make a diagnosis of stress cardiomyopathy. Initially, it was a Mayo Clinic criteria, And it basically has a similar point that we just talked about. It's just more explanation of that. Transient left ventricular systolic dysfunction could be hypo, could be akinetic, or could be dyskinesis. Absence of, now one thing I would like to highlight here, when we talk about the wall motion abnormality in the echocardiogram, that has to be beyond a single epicardial coronary vessel. Suppose you're suspecting the right coronary artery is going to supply the inferior wall and the infraseptal wall. But if you're seeing that, no, it's going to other side as well, that means it's not fitting into the math that, which vessels are involved. Although there are always exceptional cases, but that's how you kind of think about the stress cardiomyopathy. Then second point is the absence of CAD, or I would say significant CAD without any acute event like a plaque rupture or a fissure. Third is the EKG findings, which could be elevation, TV inversions, less likely depression, and absence of pheochromocytoma or myocarditis, because pheochromocytoma, although it looks very similar, but only difference is that it's not a stress, it's a tumor. Now this has been replaced by American Society of Cardiology criteria, which again has the same thing, just a little bit more elaboration, few extra points. One again is a transient regional left ventricular systolic dysfunction beyond a single epicardial coronary vessel, absence of obstructive or significant CAD, new EKG changes, significantly elevated BNP, positive but relatively small elevation in cardiac troponin, and recovery of ventricle quickly. Sometimes they recover in actually within few days. And there's the latest one that they propose, that what called the Intertech diagnostic criteria. And again, they assign points depending on your risk factor. And if you see that, it's more than 50, then it's pretty 95 specific that it could be a stress cardiomyopathy. So again, this disease is not without any complication. About 10 to 25% of the patient present with cardiogenic shock, which could be because of simple left ventricular systolic dysfunction, or could be because of left ventricular outflow tract obstruction. These patients are at very high risk for arrhythmia, because if you see, I'm not sure how many have you noticed actually, in a stress cardiomyopathy, if they repeat the EKG after 48 to 70 hours, you would probably see a very wide QT interval, sometimes going all the way up to 640 milliseconds, and these patients are at risk for ventricular arrhythmias. That's why these patients need to be closely monitored, avoiding any medication that can cause further prolongation of QT interval. Now, since the apex is involved, you can have a sluggish blood flow in the apex that can cause a clot, and sometimes actually the first initial presentation of some of these patients is actually stroke, because the clot from the heart goes to the brain, and very rarely you can have a myocardial rupture and hemorrhage. So differential diagnosis, yes, acute coronary syndrome, and the only way to basically find out is do an angiogram. Second is cocaine. With the cocaine, you probably get a history of cocaine. If you do an angiogram in this patient, you may find spasm of the coronary arteries. Pheochromocytoma, again, catecholamine level is going to be very high. It's a little difficult to make a diagnosis, but it's pretty much the same pathophysiology. Only difference is the etiology is different in this case. And myocarditis. In myocarditis, we usually have a patchy appearance of wall mesh abnormality, either the basal segment or the lateral wall. If you do an MRI in these patients, you may find delayed gadolinium enhancement, which we do not see in patients with stress cardiomyopathy. So treatment. The treatment of this patient is mostly supportive care. If the patient is in shock, and that shock is not because of outflow tract obstruction, you might have to use a mechanical circulatory device sometimes. This patient needs to be monitored in telemetry at least for 48 to 72 hours. If they're in heart failure, then you start the standard treatment for a HFrEF. However, compared to other cardiomyopathy, actually the beta blocker and the ACE inhibitor, which are the hallmark of the treatment of a cardiomyopathy, these medicines are not beneficial in these patients. The beta blocker has not shown much difference in mortality at 1 year or short term. However, beta blocker does decrease the risk of arrhythmias. Similarly, with the ACE inhibitor, not much mortality benefit. We don't have a randomized controlled trial. All this data is based on small studies, and some studies say maybe ACE inhibitor is better, but again, without any randomized controlled trial, this is just expert opinion and small studies. And then you prevent a thromboembolism, because these patients are at high risk for a clot formation in the apex. This is just a diagrammatic representation of a patient, how to manage a patient with stress cardiomyopathy. So you see a patient with stress cardiomyopathy. If the patient is in congestive heart failure, then you start the patient on HFrEF treatment, which will include diuretics, decrease the afterload, beta blocker, ACE inhibitor, at least at this point of a time. If the patient is in shock, you need to find out is the patient in shock because of severe left ventricular dysfunction or because the patient has a left ventricular outflow tract obstruction. And this determination is very, very important, because if you think that patient is in shock, and what we do in patient in the shock, you start the patient on inotropic agent. What you're going to do, you're going to worsen the stress cardiomyopathy, first of all the catecholamines, and second is that the basal segment of the heart, which is already hypercontractile, is going to be more hypercontractile, and what will happen, then you will have a complete obstruction of left ventricular outflow tract, and patient actually may code or die, but at least the patient will not improve but get worse. If you do is that patient has left ventricular outflow tract obstruction, then what you're going to do, you have to decrease that obstruction in outflow tract. The way you do that, you give some fluids, unless the patient is in pulmonary edema. You may try some beta blocker, because beta blocker decrease the contractility of the basal segments. And if these things does not work, then you can just try a simple afterload medication like a neosynephrine, which only improves the afterload and decrease the outflow tract obstruction. So this disease is not free of recurrence. There's about 2 to 4% recurrence every year and about 20% recurrence at 10 years. Unfortunately, we do not have any definite treatment for long-term management. A beta blocker is recommended again by some expert in patients who have persistent anxiety, elevated heart rate, persistent has chest pain. Then you may try a beta blocker that may give some benefit. Again, that is without any randomized controlled trial. Marginal benefit of ACE inhibitor, but most important thing is the assessment and treatment of psychiatric issues. If you remember, or if you recall from my third, fourth slide, that more than 50% of people actually have psychiatric problem, high element of anxiety, depression, and if you continue to have this risk factor, then you're more likely to have stress cardiomyopathy in future. So that is actually is a main treatment. Prognosis, it has a mortality of about 5%, so it's not the simple disease that it was thought to be. Recovery actually is on an average 1 to 2 weeks, but can take up to 6 weeks. But I've seen in my practice that many times within 48 to 72 hours, the patient shows some sign of improvement. Now, if the patient develops recurrent stress cardiomyopathy, sometimes you can have irreversible cardiomyopathy which never recurs. So this is a little bit of contradiction to my first slide of a definition in which it says that it has to be reversible. So there are some case studies in which the patient has irreversible cardiomyopathy because of frequent attacks of stress cardiomyopathy. Now, this disease is not commonly seen in younger people, as I mentioned before, but in one of the registry, basically 1.9% were younger patients. And in the younger patient, you always have to look for some kind of drug abuse, alcohol abuse, because these are likely the trigger for a stress cardiomyopathy. In female is an anxiety, depression problem. And younger people actually, they more commonly have atypical variant like a mid-ventricle or reverse compared to typical apical stress cardiomyopathy. Unfortunately, there are a lot of questions that are still not answered. I mean, most of the questions I try to answer are based on small trials, animal model study, basic science research, but we still don't have we still need a better understanding of the pathophysiology, why it's more common in females than males, although we did mention that it's likely the anxiety and depression, but never been proven. We still do not have a definite study which says that, okay, you look at the study and you say, oh, this is stress cardiomyopathy. Stress cardiomyopathy is all about, excluding a significant coronary disease. And unfortunately, no randomized controlled trial for the treatment. And thank you.
I've worked a lot with our registry that we have at the hospital, and we're, like you said, 174 or more patients. I've looked at it a great deal, and I would like to thank Dr. Bajaj for probably, the most comprehensive review of cardiomyopathy, stress cardiomyopathy I've ever heard. It covered every single point, and it was tremendous. So thank you very much.
Thank you, Dr.
In our series, we had 10 to 12% recurrent rate. And we had one patient who's actually had 5 episodes of stress cardiomyopathy. So it can recur over and over again. I went and looked at meds pre and post in our group of people, and roughly 50% of the people were on some sort of psychiatric medication at the time of their initial presentation. So it fits right in with the statistics and everything that, that you laid out for us today. So very definitely, you know, increased severity. I think we never described it when we were in medical school or fellowship or anything. I don't remember a single case until I got to Rapid City, but I think it's just going to be more and more common with time just because of society and the way things are. So, questions?
Thanks, Anurag. I've had a burning question, and I actually posed it to one of my colleagues at Mayo Clinic years ago. You know, we didn't see this very much back in the 80s, 90s. There were some cases where we thought, well, maybe it's spasm, you know, we would throw that around, and I think still that was quite a bit less common than what we see with this. So the big thing that changed in my mind was the HERS trial in 2001, where they stopped prescribing postmenopausal hormone replacement therapy. And I had asked the Mayo guys to dig into this, and I don't think they wanted to do it at the time, but to this day, that's still one of my running theories, is why is it postmenopausal women other than, you know, hormone removal? So.
And I think too, historically, you look back at, and you see all these people that have had, you know, quote, heart attacks in the past, and then you come in and you see them in the clinic and you do an echo and their LV function's normal and their EKG is normal, and they said, well, you know, they did an angiogram, but nothing needed to be fixed, and you kind of, you know, not sure that you believe the history. But a lot of times I think that was probably what was happening and just under-recognized by cardiologists and everybody else.
Yeah, I think that people are more vigilant now because, you know, we all know that there's an entity called a stress cardiomyopathy. Previously it was like, okay, weak heart, no obstructive CAD, go home, maybe likely viral. But as more and more case studies and reports came out, we actually know that there's something called stress cardiomyopathy. We'll look for it, and we look for the pattern. So I think that's the reason that, you know, we are seeing more and more cases. And I feel that, you know, the actual prevalence is higher than that because, you know, it says 1 to 2%, you know, but whenever I'm in hospital rotation in a week, I think I never had a week where I never saw a stress cardiomyopathy. Every week there's always one patient with stress cardiomyopathy. And I think that you mentioned about the postmenopausal women, I think I mentioned in one of my slides, you know, again, it's just a hypothesis. They have more element of anxiety and depression. They have microvascular dysfunction that may be the trigger for a stress cardiomyopathy in these patients.
Is there any role for acute administration of psychiatric anxiolytic medications during the attack?
I did not encounter, you know, in any literature that if you give someone with the anti-anxiety medication, something like that, is going to help the stress cardiomyopathy. In long run, yes, it definitely beneficial, but in acute setting, I don't know.
And again, kind of looking at our registry, looking back at it, because it goes from 2014 to 2023, I did not find, we had a couple of patients that were really close to dying with their acute event, and cardiogenic shock and everything required a much longer period of time to recover, but eventually they recovered. I have yet to find one individual out of that 174 plus patients that actually ended up dying of a cardiac disease that we knew of. Almost all of them COPD, bad COPD, they come back in with COPD exacerbation, or they end up dying of their respiratory failure. And respiratory by far and away is the most common, as was pointed out. And so I think it's interesting that out of all of those cases, there was not one single cardiovascular death that I could definitely pinpoint. And we did have some that had both coronary disease and stress cardiomyopathy I threw that out of the equation. They weren't in the group, even though they did have some obstructive coronary disease. If they had any intervention, they were thrown out of our group. But there is a significant percentage, probably less than 10%, that have the combined coronary disease, and that sometimes got fixed, but mostly it was stress cardiomyopathy.
And sometimes the patient actually have a concomitant stress cardiomyopathy along with their MI. So I had a patient who had a STEMI with an inferior wall hypokinesis, but the patient also has a apical segment which is hypokinetic. And it's like, oh, I can't explain that based on the coronary anatomy, but then you repeat the echo in 48 hours and you see that the apex gotten better, but the base is because of the infarct. So there are cases as well with a non-STEMI or a STEMI with a stress cardiomyopathy.
Okay. Other questions? Thank you, Dr. Bajaj.
Okay, thank you.